All right, it's 12 o'clock. So we'll go ahead and get started. Apologize for my voice, a little post-viral sound here. But welcome to Medical Grand Rounds at the University of Colorado. Very happy to have everyone back in person this year. We will, of course, be keeping the Zoom link open, but we encourage you all to come to the second floor of RC2, the Krugman Conference Hall, in person as often as you can, because I think it is nice just from a community building experience. As a programming note, upcoming, there's no medical grand rounds next week. We hope all of you have the opportunity to spend some time with family for the Thanksgiving holiday. But we will be back with a strong lineup in December. Dr. Anuj Mehta will be speaking. Dr. Chopra will also be speaking in December with a State of the State. We will also have, excitedly, our first medical grand rounds by the Chief Medical Resident class this year at the end of December. As a reminder, you can use the QR code here to get CME and MOC credit for all grand rounds this year. So I'll leave it up there for just another second. And questions will come primarily from our live audience for Dr. Lahm, but we will also be taking questions, again, thank you to the Chiefs, through the Q&A feature on Zoom. And now I really am pleased to welcome today's speaker, Dr. Tim Lahm. Dr. Lahm is a professor of medicine and pulmonary vascular biology in the Department of Medicine here at CU, within the Division of Pulmonary and Critical Care, with a clinical practice at the VA hospital as well as at National Jewish. He did his undergraduate work combined with medical school training in Heidelberg, Germany. After an internship in anesthesia in Germany, he then came over to the States and did his internship and residency at the University of Indiana School of Medicine. He stayed at Indiana for his pulmonary fellowship training and also received advanced research training in the effects of estrogen on pulmonary artery vasoreactivity and the acute hypoxemic pulmonary vasoconstrictive effect, as well as separately on the effect of antiretroviral therapy on BAL pro-inflammatory cytokine expression. Dr. Lahm then stayed in Indiana for a number of years, where he had a very successful and productive career throughout his junior faculty and mid-career time. We were fortunate to recruit Tim to Colorado just last year in 2021. He is an expert in pulmonary arterial hypertension and pulmonary hemodynamics. His work is currently sponsored and supported by the NHLBI, the VA, and several sources of industry funding. And this, of course, is built on a career being continuously supported since his time in fellowship, which is an impressive accomplishment. His work to date has led to over 50 publications, over 100 invited lectureships nationally and internationally. And he really does a significant amount of service on a national level, very involved through the ATS and other organizations at getting the word out about the work that he does. In addition to his impressive clinical and research work, Dr. Lahm really has been recognized as an incredible educator, but also as a mentor. He has mentored or co-mentored over 50 other fellows and faculty, many of whom are in the process of or have already achieved successful academic careers. And he's won a number of teaching and educational awards throughout his time. So it really is a pleasure today to welcome Dr. Tim Lahm to Medical Grand Rounds.
Thank you for the very nice and kind introduction, Jeff. And thanks a lot for having me. I'm super excited to be here in Colorado. It's been a long professional dream of mine to move out west. So I'm super excited to be here. And it's a real honor and a pleasure to present at Grand Rounds today. Okay, these are my disclosures. So what I would like to do in the next 45 minutes or so is talk briefly about what is pulmonary hypertension or PH and why is it important. I will then talk about what is currently known about sex and gender differences in the pulmonary vasculature and right ventricle, specifically in pulmonary arterial hypertension. And we will focus on sexual dimorphisms in PAH severity, as well as susceptibility, right ventricular adaptation, and outcomes and mortality. I will then talk briefly about what are the molecular mechanisms that underlie these sexual dimorphisms, and towards the end of the talk about what are the implications for patient care. So I wanted to start with a case of two patients with pulmonary arterial hypertension, or PAH. The first patient is a 42-year-old woman with idiopathic pulmonary arterial hypertension. Her mean pulmonary arterial pressure is 36 millimeters of mercury. Her pulmonary vascular resistance is 7 Wood units. Her cardiac index is 2.4 liters per minute per meter square. Her echocardiogram shows right atrial and right ventricular dilatation, but normal right ventricular systolic function. Her brain natriuretic peptide level is 48, and her 6-minute walk distance is 350 meters. The second patient is a man, same age, You can see the pulmonary artery pressure is the same, the pulmonary vascular resistance is the same. Cardiac index is lower though at 2.1 liters per minute per meter square. And that patient on his echocardiogram has a moderately decreased right ventricular systolic function. BNP level is elevated at 228, and his 6-minute walk distance is 380 meters. So questions that I wanted to answer throughout this talk are, which of these patients has a higher risk of dying in the next 5 years? And should these patients receive the same treatment or should they get different treatments? And should they maybe be enrolled in a clinical trial targeting modification of sex hormone signaling? So we'll come back to these questions towards the end of the talk. So this is the current clinical classification of pulmonary hypertension, or PH. You can see it's pretty busy, but PH is a syndrome of diseases that are all characterized by an elevation of the mean pulmonary artery pressure to a value of 20 millimeters of mercury or more, as well as pulmonary vascular remodeling. The first group is known as pulmonary arterial hypertension, or PAH, and this entails idiopathic PAH as well as heritable PAH, PAH that is due to drugs and toxins, as well as PAH that is associated with various conditions such as connective tissue disease, HIV infection, portal hypertension, congenital heart disease, and schistosomiasis, which of course is a very big problem worldwide. Group 2 is PH due to any type of left-sided heart disease, LV systolic dysfunction, diastolic dysfunction, or valvular heart disease. Group 3 PH is PH that is due to lung disease, chronic hypoxemia, severe sleep disordered breathing, or other chronic hypoxemic conditions. Group 4 is PH due to pulmonary artery obstructions. So the prime example here would be chronic thromboembolic pulmonary hypertension. And group 5 really is a hodgepodge of types of PH that have multifactorial and unclear mechanism. And this includes diseases such as hematologic disorders, metabolic disorders, sarcoidosis, thyroid disease, end-stage renal disease. You can see it's a very diverse group of conditions. So the pathobiologic features of severe pulmonary hypertension are shown on this slide. You can see here a normal pulmonary artery with a very thin intima, media, as well as adventitia. And then in the setting of pulmonary hypertension, and this really occurs in all 5 types of pulmonary hypertension, you can see there's profound pulmonary vascular remodeling with intimal fibrosis, apoptosis and proliferation of endothelial cells. There's medial hypertrophy and smooth muscle cell hyperplasia, inflammatory cell recruitment to the adventitia with fibroblast proliferation and collagen disruption. And then in the most severe types of pulmonary hypertension, and this is fairly specific to pulmonary arterial hypertension, patients develop these plexiform lesions where the lumen is completely distorted. You can see this almost looks like cancer. And it really does not take a lot of imagination, and it will be very difficult for the right ventricle to pump blood into a pulmonary vascular bed that looks like this. So the hemodynamic progression of pulmonary hypertension is shown here on this slide. You can see as the pulmonary vascular remodeling process is progressing, the pulmonary vascular resistance will increase, and then the mean pulmonary arterial pressure will follow suit and increase as well. Cardiac output will initially be maintained, but eventually these patients will develop right ventricular failure. And then they may present with an echocardiogram that looks like this, where you can see a profoundly dilated right ventricle as well as a profoundly dilated right atrium. And hemodynamic adaptation of the right ventricle to this increased pulmonary vascular resistance is really what determines survival in pulmonary hypertension. So this is shown here on this slide. Again, you can see that the mean pulmonary artery pressure as well as the pulmonary vascular resistance progressively increase. The right ventricle will then respond with a remodeling process and a hypertrophy process that initially will be adaptive, meaning the RV will be able to maintain necessary cardiac output for these patients. But then as the remodeling process progresses, the RV will transition into what we call maladaptive RV remodeling, where it will not be able to maintain an appropriate cardiac output cardiac index. And again, this is when patients present with right ventricular failure. At a molecular level, this remodeling process is characterized by worsening alterations in angiogenesis, mitochondrial function, calcium handling, and sarcomere organization, as well as increasing degrees of inflammation, neurohormonal activation, fibrosis, oxidative stress, metabolic dysfunction, and cardiomyocyte apoptosis. And the group from Netherlands very nicely showed a few years ago that this RB adaptation really is the primary determinant of survival in pulmonary hypertension. You can see here in green and black, these are patients with a PAH and a maintained right ventricular ejection fraction, whereas in red and blue, you see patients with a decreased RVEF. And you can appreciate that the survival in those patients with a decreased RVEF is much worse as compared to those patients that have a maintained right ventricular function. And this was really independent of the degree of afterload increase. So as soon as the right ventricle goes down in pulmonary hypertension, survival is very, very detrimental. The current therapeutic strategies for PAH are shown here. There are currently three major pathways that are being targeted. Endothelin is a known vasoconstrictor and pro-proliferative agent. This pathway is upregulated in PAH, and it is currently being targeted with various endothelin receptor antagonists. Prostacyclins and nitric oxide are known vasodilators and anti-proliferative agents. These pathways are downregulated in PAH, so we try to enhance them therapeutically. In case of the prostacyclin pathway, we do this with various prostacyclin analogs, as well as prostacyclin receptor agonists, such as Lexapag. And the nitric oxide pathway is targeted through either riociguat, which is a soluble guanylate cyclase activator, or phosphodiesterase type 5 inhibitors, sildenafil and tadalafil. What these compounds do, they will increase cyclic GMP, leading to vasodilation and inhibition of proliferation. And then we are very excited in the field. As of last year, we also have a treatment option for PH due to interstitial lung disease. This is inhaled treprostinil, again targeting the prostacyclin pathway. And chronic thromboembolic pulmonary hypertension is targeted surgically through a pulmonary thromboendarterectomy. And in case of inoperable disease, patients can be treated with balloon pulmonary angioplasty or riociguat, again targeting the nitric oxide pathway. And then a very exciting development in the field is there's a new therapy on the horizon that is specifically focused on targeting anti-proliferative signaling. And this is shown here on this slide. So there's essentially an imbalance of pro-proliferative and anti-proliferative signaling in the pulmonary vasculature. And what you can see here is that activins and growth differentiation factors target the activin receptor 2A, which then leads to pro-proliferative signaling in the pulmonary vasculature. And at the same time, the anti-proliferative BMPR2 pathway is inhibited when this pathway is activated. So the idea here is to inhibit activin and GDF signaling with a drug called sotatercept, which then will decrease this pro-proliferative signaling and enhance anti-proliferative BMPR2 signaling. And the results from the phase 2 study actually came out last year, and we were all very excited in the field because you can see there was indeed a fairly profound dose-dependent decrease in pulmonary vascular resistance with sotatercept therapy. And the University of Colorado was actually a site of the study here. The phase 3 trial has just been completed. Results have not been published yet, but per press release, 8 out of 9 endpoints were met. So again, there's a lot of excitement in this field about this potential new and very potent therapy. Okay, so let's talk about sex and gender, and why does a pulmonologist talk about that, and why do we need to care about this? Well, sex, as many of you may know, is actually a major biological modifier and variable. Again, I'm a pulmonologist, so I just listed several lung diseases here that have sexual dimorphisms. And you can see that's actually a pretty long list, right? And I could show you lists like this for other medical conditions in cardiac disease, endocrine disease, autoimmune disease. Again, there's lots of examples. So since sex was really not considered adequately as a biological variable, the NIH a few years ago launched this new policy to really consider sex as a biological variable in research and clinical care. And for those of you who write NIH proposals, this is something that now needs to be addressed on a regular basis. The NIH has held several workshops over the years focusing on this in lung disease, but also other diseases. And there's actually books that have been written on this chapter. And this is a really nice book if you want to read more about sex differences, specifically in lung disease. So when we talk about sex differences, we need to talk about this concept of sex versus gender, because sometimes this leads to confusion. So sex is a biological concept. This pertains to the study of chromosomes, reproductive organs, hormones, and also to the studies of cells in animals. Gender, on the other hand, is a socio-cultural construct. So this pertains to the study of roles, responsibilities, attributes, behavior, and entitlements. So for example, if you have patients with acute coronary syndrome and the time to hospital arrival is longer in women than in men, that is a gender difference because there's probably social cultural influences here. On the other hand, in the lab, when we study pulmonary artery smooth muscle cells and female cells grow faster than male cells, that's a sex difference. Female rats have a higher cardiac index than male rats, that's a sex difference. Then also, of course, women have 2 X chromosomes, men have 1 X and 1 Y chromosome. That's also a sex difference. And then if you have patients with chest pain and you have a male provider that is more likely to order a stress test for men than for women, that's actually an example of a gender bias. Okay, so just very important that we use the right language when we talk about these things. So what is currently known about sex and gender differences in pulmonary arterial hypertension, as well as other types of PH? This here is a really busy slide. I'm not going to go through details, but what we did here, we listed the 5 main groups of pulmonary hypertension that I reviewed a few minutes ago, and in yellow highlighted sexual dimorphisms. And you can see that such sex differences actually are observed in all 5 groups of pulmonary hypertension. And really, the big theme here is that women are more prone to developing PAH. Gender differences exist in disease metrics and treatment responses. And then interestingly, women with PAH, even though they are more prone to developing this disease, once they develop PAH, actually exhibit more favorable hemodynamics, better RV function, and better survival. And we'll talk about these things in more detail here on the next slides. So let's start with gender differences in disease susceptibility. It has been known for a really long time that PAH is a female predominant disease. In fact, the first report in the modern or relatively modern area by Drysdale reported 3 patients that were all women. And then we have learned over the years in various registries that have been performed all over the world that the female to male ratio in PAH is as high as 4:1. So it's ranging anywhere between 1.7 to 4:1. And again, this is seen all over the world. So this then raises the question, why is that, right? Why is PAH a female predominant disease, and what are the modifiers? And there has been a lot of research been done in the last 20 years or so looking into that. And here's just a list of various publications that have shown that estrogens might actually promote pulmonary vascular remodeling in the pulmonary artery. And this could be like a whole talk in and of itself. Just to highlight a few key concepts here, we know that levels of 17 beta estradiol or E2 correlate with worse outcomes in PAH. E2 may promote pulmonary artery smooth muscle cell proliferation. estrogen may decrease this anti-proliferative BMPR2 signaling, specifically in pulmonary artery smooth muscle cells. Interestingly, there is increased expression of aromatase, so that's the enzyme that's, as you know, responsible for making estrogen. So increased aromatase expression, specifically in the pulmonary vasculature. And there's increased production of an estrogen metabolite called 16-alpha hydroxyestrone, which is a known mitogen and pro-inflammatory mediator. So this is the estrogen part, and whenever you talk about sex differences or gender differences, people automatically think about sex hormones and estrogens. That's usually the first thing that comes up. But there are also non-sex hormone modifiers at play. Of course, you know, we have X chromosomes, we have Y chromosomes. Men have an X and a Y chromosome. So a group from UCLA a few years ago asked, well, is maybe something going on with the Y chromosome here? Is something going on here with the Y chromosome? And is maybe the Y chromosome encoding genes that protect you from developing PAH? And in a paper that was just published this year, they identified a gene called UTY that is encoded on the Y chromosome that actually may exert anti-inflammatory effects in PAH and protect from PAH development. So this study is shown here. What the authors did is they had male mice and knocked out this UTY gene. And you can see in the animals where UTY was knocked out, when these were exposed to hypoxia, these animals exhibited a higher right ventricular systolic pressure as compared to the wild type. And then in a series of really nice and elegant experiments, they showed that loss of UTY is associated with increased expression of pro-inflammatory cytokines, especially CXL9 and 10, which then leads to macrophage infiltration, endothelial cell dysfunction, and endothelial cell apoptosis, and triggering the pulmonary hypertensive phenotype. So very interesting study. I liked it because they really took a novel approach to deciphering the underlying basis for sex differences in PAH. Okay, so this is the susceptibility part. Let's talk about gender differences in disease metrics. This is a really interesting study that also came out this year by my friend Corey Ventitulo. Corey looked at almost 7,000 participants in various trials of pulmonary arterial hypertension medications, and essentially just asked the question, are there gender differences in disease metrics? And the answer is yes. So here we see data for 6-minute walk distance. Men are shown in blue, women in pink, not surprisingly. And you can see that the men actually exhibit a higher 6-minute walk distance compared to the women. And this held true when both age as well as BMI were considered as modifiers of this relationship. And then similarly, when Corey looked at hemodynamic endpoints, she saw interesting gender differences here. So right atrial pressure was higher in men than in women. The pulmonary artery pressure was higher in men as compared to women. And the cardiac index was lower in men compared to women. And you can also see that most of these differences actually occurred in the younger end of the spectrum, suggesting that possibly things like menopause or sex hormones may be modifiers of this relationship. Okay, what about treatment responses? So this is another area where sexual dimorphisms exist in PAH. This is an analysis of 6 randomized placebo-controlled trials of various endothelin receptor antagonists in PAH. And what these authors found was that female PAH patients actually are more responsive to treatment with ERAs compared to men. So you can see here the difference in 6-minute walk distance in women. So this is ERA versus placebo. On average was 44 meters. In men, it was only 16 meters, meaning that actually the difference in women was 27 meters more compared to men. And this held true across various models with different types of adjustments. So women more responsive to ERAs. But then on the other hand, men seem to be more responsive to treatment with phosphodiesterase type 5 inhibitors. This is an analysis of the tadalafil trial, also known as FIRST trial. The authors here looked at the fraction of patients achieving the primary endpoint, which was 6-minute walk distance in this case. And you can see the fraction of patients achieving the primary endpoint was about 25% higher in men compared to women. And then lastly, let's talk about gender differences in outcomes. And this is obviously incredibly important. I told you that women are more prone to developing PH. And again, this has been known for a long time. But about 12, 13 years ago, we actually learned that women with PH exhibit better survival than men. This was really the landmark study done in this field by Marc Humbert from France. And Marc showed that the hazard ratio for dying in PH was much lower in women as compared to men, as you can see here. And this has since then been replicated in various cohorts across the world. This is from a Dutch study. And again, you can see survival in female PH patients is higher as compared to male patients. This is a PAH cohort. So then the question is, what about other forms of pulmonary hypertension, your group 2 disease, group 3 disease? Are there any survival differences as well? And the answer is yes. This is a large study where we looked at the VA CART cohort, which is actually based out of Colorado. We looked at 15,000 patients with right heart cath confirmed pulmonary hypertension. Again, these are all types of PH, a lot of group 2, a lot of group 3. And again, you can see survival in women patients is higher as compared to men patients, to male patients. Okay, so I discussed with you a few minutes ago that right ventricular adaptation is the major determinant of survival in PH. So if men don't have outcomes as good as women, does this have something to do with their right ventricular adaptation? And the answer here is yes. This is a really cool study that my friend Steve Kaywood did about 13 years ago. And Steve looked at right ventricular ejection fraction in men and women with PAH using cardiac MRI. And Steve found that indeed the women had a higher right ventricular ejection fraction as compared to men. And this held true when adjusted for things such as body mass index, left ventricular size, so really rigorously adjusted. And this difference still held up there, suggesting that maybe better RB adaptation is what promotes better survival. And this study from the Netherlands that I just showed you on the previous slide actually confirmed that. And they showed that about 40% of the survival difference between male and female patients can be explained by a better right ventricular ejection fraction in women. And again, this is not just true for pulmonary arterial hypertension. This also holds up for other types of PH. This again is the VA cohort study that I just showed you on the previous slide, where we found that the right atrial pressure was actually lower in women with PH as compared to men, suggesting that there might be a better right ventricular adaptation and therefore lower right atrial pressure. And another study that just got published about 2 years ago from University of Minnesota looked specifically at patients with group 3 PH. So again, this is PH due to chronic lung disease. And you can see here that females with group 3 PH have a higher right ventricular fractional area change as compared to men. So RV fractional area change, the higher the better. So this essentially indicates better RV contractility. And what was very surprising is this was observed even though the women had a higher pulmonary vascular resistance. So despite a higher RV afterload, these RVs seem to be better adapted in group 3 PH. Okay, so these studies that I just reviewed used either echocardiography or cardiac MRI to assess RV function. But really the kind of gold standard for assessing right ventricular adaptation in pulmonary hypertension is what's called the pressure-volume relationship. And this is something that might be familiar to you from medical school and from physiology. So what we do here is, so you essentially insert a catheter. So it's a modified catheter that goes into the right ventricle. you measure pressure and volume, and then you get these pressure volume loops that you know from med school, right? This point here is the end systolic pressure. If you then do something like a Valsalva maneuver and look at various points over various cardiac cycles, you get what's called the end systolic pressure volume relationship. And the slope of this curve is called EES, or end systolic elastance, which is a measure of right ventricular contractility. Okay. If you connect end systolic pressure with the end diastolic pressure and look at the slope of this curve, you get what's called arterial elastance, or EA. So this is a measure of RV afterload. And if you look at the ratio of the two, so EES over EA, this is really the gold standard for assessing what we call ventricular arterial coupling. So really the question here is, if you have an increase in pulmonary vascular resistance, your right ventricle will respond with increased contractility. But does it respond enough to overcome this increased pulmonary vascular resistance? This is really the question that you're trying to answer when you look at this concept of ventricular arterial coupling. So you can see a couple of examples here. So this here in blue is an RV where the EES over EA ratio is 2, and this would be consistent with what we called maintained coupling. So this is an RV that is essentially able to generate enough squeeze to overcome the increased RV afterload. On the other hand, here on the right, in this kind of reddish color, you can see that EES over EA is only 1.3. So this would be suggestive of an uncoupled RV, essentially an RV that is failing. Okay. So we asked the question, are there gender differences in RV-PA coupling in PH? And to address this, we teamed up with Codartello at the University of Gießen. We looked at a cohort of 57 patients with various types of pulmonary arterial hypertension. You can see this was a pretty advanced disease and cohort. A lot of these people were on dual or triple combination therapy. And interestingly, when we looked at the traditional hemodynamics that you get with a traditional right heart catheterization, there were actually no gender differences between any of these groups. But then when we looked specifically at RV contractility, so this is end systolic elastance, ES, you can see that this was higher in women as compared to men. And this was the case when we looked at the entire cohort, as well as specifically patients with idiopathic pulmonary arterial hypertension. And then similarly, when we looked at RV-PA coupling, so ES over EA, again, you can see that the female RVs actually exhibit better coupling than the male RVs. And interestingly, when we looked at RV diastolic dysfunction, that's actually another parameter you can get with pressure volume loops by looking at this tau parameter here. You can see this value was lower in women compared to men, suggesting better RV diastolic function. And this was accompanied by a lower right ventricular mass in the women as compared to men when normalized for body surface area. So just to summarize what we discussed so far, there are gender differences in PAH prevalence, disease metrics such as 6-minute walk distance, hemodynamics, and treatment responses. Women with PAH and other types of PAH exhibit better RV adaptation and survival than male patients. Women with PAH exhibit better RV coupling and RV diastolic function than their male counterparts, as I just showed you. Okay, that's actually it. So when I think of sexual dimorphisms in pulmonary hypertension, there actually, as you can see here, are a lot of potential players that could play a role here. Obviously, sex hormones could play a role here. Sex chromosomes could play a role, as we reviewed. But then there are also other things such as environmental factors, exposures, behavioral and social economical factors, genetic factors such as mutations in the BMPR2 gene, comorbidities, immune-mediated mechanisms, as well as metabolic factors such as alterations in glucose and lipid metabolism. All these things have been implicated in sexual dimorphisms in PH. In my lab, we are specifically interested in the study of sex hormones and specifically estrogen and its metabolites. So to understand this better, I actually have to take you back again to medical school or grad school and just remind you of the basic biology of 17-beta estradiol, or E2, and its receptors. You may recall this is the most abundant estrogen in both men and women. And being a steroid hormone, E2 diffuses through the cell membrane and then forms a complex with one of its two receptors, either estrogen receptor alpha or estrogen receptor beta. We refer to them as ER alpha or ER beta. And then this E2 ER complex then translocates to the nucleus where it binds to estrogen response elements and acts as a transcription factor that is then regulating gene expression. And interestingly, these ERs are widely present throughout the body, not just the reproductive system. They can also be found in the cardiovascular system, in the respiratory system, central nervous system, immune system, skeletal muscle system. So these receptors are widely present throughout the body. There are differences in tissue distribution, though, as well as differences in functions. So what is the evidence that E2 is a mediator of sex and gender differences in PAH and other types of PAH? This is another study by Corey Ventitulo, and Corey found that in PAH patients, plasma levels of 17-beta estradiol are significantly higher as compared to controls. This was really the first study that implicated plasma estradiol levels as a possible disease mediator or modifier. But of course, this is circumstantial evidence, right? But as we talked about towards the beginning of the talk, there's actually a lot of literature out now that demonstrates that estrogens as well as estrogen metabolites indeed may promote pulmonary vascular remodeling. But then on the other hand, I showed you that female PAH patients exhibit better survival and better RV function, right? And our lab, as well as other labs, have shown that estrogens indeed exert protective effects, specifically in the right ventricle. So how does E2 exert these RV protective effects in PAH? This is something that we've been working on for the last 10 years or so. And we think this is an important question because a better understanding of mechanisms of E2 signaling in the RV may provide the basis for a personalized and gender-specific approach to treating RV failure in PAH as well as other types of pulmonary hypertension. So a few years ago, we did a study where we employed the Sugen hypoxia rat model of pulmonary hypertension. And here we found that female Sugen PH rats exhibited better RV function than male rats. Ovarectomy then worsened RV function in the females. And when we gave estradiol back to these overrectomized females, we could restore RV function. And this is a pretty big study. It was a lot of work. I just wanted to kind of summarize the key results here. We found that E2 in the RV attenuated pro-apoptotic signaling as well as pro-inflammatory signaling. It attenuated metabolic and mitochondrial dysfunction as well as oxidative stress. And E2 increased expression of a pro-angiogenic and pro-contractile peptide called apelin. And we think all these things in concert then led to better RV function as well as better exercise capacity in these animals. And we also found that treatment with an ER alpha selective agonist was actually able to replicate E2 mediated protection, suggesting that maybe estrogen receptor alpha is mediator of estrogen's protective effects. So to study this in more detail, we teamed up with Sébastien Bonnet and Steve Promonchet from University of Quebec. They have a very robust tissue bank with human RV tissue. So we looked at ER alpha expression in RVs from either control subjects or subjects that died of right ventricular failure from pulmonary arterial hypertension. And we looked at ER alpha expression, which is shown here in red, specifically in the cardiomyocytes. And you can see that ER alpha expression was profoundly decreased in those patients that had RV failure as compared to control subjects. And this was true when we looked at the total cardiomyocyte ER alpha expression, as well as when we looked specifically at cytoplasmic expression and nuclear localization. So to study the role of ER alpha in more detail and to ask the question, is ER alpha really important for RV adaptation? we teamed up with colleagues from the University of Wisconsin, Nomi Chesler, Jin Sun, Dustin Rubenstein, and Kathy Krenz, and generated rats with ER alpha loss of function using CRISPR-Cas9. You can see these rats still exhibit a little bit of ER alpha RNA, but obviously this is decreased significantly compared to control. So this is why we call them mutants and not knockouts. But they do have uterus atrophy. They are infertile, so we clearly have a phenotype in these animals. And then we employed these rats to see whether loss of ER alpha results in decreased RV adaptation in pulmonary hypertension. And these are studies that are known by Andrea Frump, who was a postdoc in my lab. I know several of you know Andrea. And what Andrea did is she took male and female wild type or ER alpha loss of function mutants and just employed a traditional monocrotaline model of pulmonary hypertension where these animals get a dose of monocrotaline, which causes profound pulmonary vascular remodeling and RV failure. And then 4 weeks later, we did endpoint analysis. And when we looked at the cardiac index in these animals, we found that in the wild type, actually, RV cardiac index was maintained compared to untreated controls, which is not completely surprising because there were a lot of females in this group, and we know female monocrotaline rats actually don't develop a very robust phenotype as compared to male rats. But when we knocked down ER alpha, you can see that these mutants actually had a significant decrease in RV cardiac index as compared to their wild type animals, suggesting that ER alpha indeed is important for RV cardiac protection. We then employed these animals to ask the question, is ER alpha necessary for estrogen to exert RV protective effects? So here we employed a Sugen hypoxia model where we either had male or overrectomized female wild types or ER alpha mutants. These animals then get a dose of Sugen, which is a VEGF receptor 2 antagonist, when combined with a 3-week hypoxia exposure and then a 4-week re-exposure to normoxia. These animals exhibit very profound pulmonary hypertension. This model was actually invented or developed here in Colorado. And then some of these animals received estradiol. And what we found was the following. I know this is a little busy, but let me walk you through it. So we see here traditional pulmonary hypertension endpoints: RV hypertrophy, right ventricular systolic pressure, cardiac index, and pulmonary resistance. Normoxia controls are shown in black, and then our wild type animals are shown here in the second and the third column. And you can see, as expected, Sugen animals developed a pulmonary hypertension phenotype. But when they were treated with estradiol, there were significant attenuations in RV hypertrophy, right ventricular systolic pressure, cardiac index was increased, and total pulmonary resistance was decreased. But interestingly, in our ER alpha mutants, again, animals without functioning ER alpha, E2 was unable to exert these protective effects, suggesting that ER alpha indeed is required for E2 to exert RV protective effects in these animals. And then coming from the other way, we wanted to see if ER alpha is necessary. Can we maybe selectively tickle it and activate it and protect animals from pH when we are doing this? So here, again, we used a monocrotaline model, and this was a rescue approach. We waited for 2 weeks and then either gave E2 or an ER alpha selective agonist at the 2-week time point, and then we did our endpoint analysis at 4 weeks. And again, we saw here that E2 was able to attenuate the pulmonary hypertensive phenotype. Again, pink is E2 versus untreated. You can see decreases in right ventricular systolic pressure, decreases in RV hypertrophy, increases in cardiac index, and decreases in pulmonary resistance. But interestingly, the ER alpha agonist was able to replicate these effects, suggesting that ER alpha agonism is really sufficient to rescue experimental pulmonary hypertension. And then lastly, the holy grail of any therapy is, of course, survival. So here we looked at Kaplan-Meier curves in animals that were either treated with E2 or ER alpha agonist, and you can see that survival in these animals was significantly higher as compared to untreated staging animals. And similarly, when we look at a pulmonary artery banding model, so here E2, either in a prevention approach or in a treatment approach, is associated with a significant survival benefit as compared to untreated PA banding rats. So we think what we identified here is a novel RV protective axis where E2 through ER alpha improves RV cardiomyocyte function. And through additional studies where I don't have time to show you, we found that a lot of these effects are mediated through apelin, again, a known pro-contractile, pro-angiogenic and anti-inflammatory mediator. And we think this is exciting because this cardioprotective E2 ER alpha apelin signaling axis may contribute to improved RV adaptation in female PAH patients. Okay, so for the last 5 minutes or so, just wanted to circle back to the clinical world and talk about a few clinical trials that are currently ongoing, looking at specifically modifying sex hormone signaling in PAH. This is a little bit of a busy slide, but what I did here is show the main biological effects of various sex hormones and their effects in animal models, as well as human PAH. And really what I want to emphasize here is that estradiol is very pleiotropic. We've talked about this a little bit during the talk. It has beneficial effects in pH, but it has detrimental effects in pH. It has beneficial effects on the RV, but it may promote pulmonary vascular remodeling. And in patients, we know that higher levels are associated with a higher risk of pH progression. So this would suggest that maybe inhibition of estrogen signaling might be beneficial in pH. We talked about this metabolite, 16-alpha hydroxyestrone. So this one's not pleiotropic at all. That's just a bad player. It's pro-metagenic, it's pro-inflammatory, it causes metabolic dysfunction. It worsens pH in animal models. It's associated with an increased risk of pH development if you have a BMPR2 mutation. So this is a pathway that may benefit from inhibition. And then DHEA, on the other hand, again, it's not pleiotropic at all. This has a lot of beneficial effects in cell studies, in animal models, and in patients, lower DHEA levels actually are associated with increased pH severity and progression. So this pathway may benefit from activation. And this is a study from Corey Ventitulo that actually informed a lot of the studies that are being performed now. You can see higher plasma levels of estradiol in PAH patients versus controls, and lower DHEA levels in patients versus controls. Testosterone, on the other hand, was not affected. So again, this would suggest maybe inhibiting this and activating that might be beneficial. So there are currently 3 clinical trials ongoing looking at sex hormone modification. Anastrozole, as you know, is an aromatase inhibitor that lowers estradiol level. So this is being performed in men and postmenopausal women in a phase 2 study. Tamoxifen is a selective estrogen receptor modulator, SERM, and a purported estrogen receptor antagonist in the lung. This study actually includes premenopausal women. Again, this is a phase 2 trial that's currently ongoing. And then DHEA is an androgen precursor. This study is being performed in men and women above 18 years of age, and again, a phase 2 trial. And the University of Colorado is actually participating in anastrozole, right, Todd? Perfect. Okay, so all of these studies are ongoing. We're all super excited in the field to see what the data will show, and I think this will inform us a lot about whether this is a therapeutically targetable axis. So just to finish this up and circle back to our patients, again, we had these 2 patients here, a woman and a man with PAH, very similar hemodynamics. That male patient has essentially less favorable RB adaptation, higher BNP levels. So which of these has a higher risk of dying in the next 5 years? Should they receive the same or different treatments? And should they maybe be enrolled in a clinical trial targeting modification of sex hormone signaling? So it turns out our female patient is at low risk for dying in the next 5 years due to the female gender, as well as the superior RB adaptation. You may wonder, that her 6-minute walk distance is actually lower than this one here, but I've shown you data that women actually have a lower 6-minute walk distance. So this might just be a function of that. And then based on data we reviewed, this patient might be more responsive to treatment with an endothelin receptor antagonist. Our male patient has an intermediate risk for death due to the fact that he's male and has a less adapted RV. And this patient might be more responsive to treatment with a PDE5 inhibitor. With regards to clinical trials, our female patient could be enrolled in the tamoxifen trial or the DHEA trial. She would not be a candidate for aromatase because she's not postmenopausal. She might not be a candidate for aromatase inhibition because she's postmenopausal. But as I mentioned, estradiol might be beneficial for RB adaptation. So in these studies, we actually have to have a very close look at RB adaptation. And some of us are a little bit nervous that this might not be a good thing of this treatment. The male patient, on the other hand, could be enrolled in all 3 trials. Again, with aromatase inhibition or tamoxifen treatment, we would have to monitor RB function closely. And then lastly, just a specific consideration in women with PH, obviously pregnancy can be a big deal in these people. You'll know pregnancy is a hyperdynamic and hypervolemic state. And there's concern that if you have like increased pulmonary or if you have an increased blood volume in the hyperdynamic state, and you need to get all this through a diseased pulmonary vascular bed and RV that's already struggling, you may throw these patients into RV failure. So survival is actually not great in PAH when patients are pregnant. Maternal mortality is as high as 25% in the modern treatment area. We therefore counsel all our patients or female patients of childbearing age that they should avoid pregnancy. We strongly recommend permanent contraception. Hysteroscopic sterilization is the preferred and least risky method. Tubal ligation or progestin-only IUDs or implants are also acceptable. And then in case of pregnancy, termination should be strongly considered just because of this very high mortality, especially in patients that are on the high risk spectrum. So with that, I would like to close. Again, we discussed that gender differences exist in PH development, endpoints, and drug responses. Women with PH and other types of PH exhibit better RV function and survival, better RV coupling, and better RV diastolic function. Sex hormones such as E2 or 16-alpha-hydroxyestrone, as well as sex chromosome encoded genes such as UTY, are mediators of sex differences in PH. E2 through E alpha mediates RV protective effects. And harnessing these sex-specific pathways may allow for novel and personalized treatment strategies in PAH. And as I mentioned, several trials are currently ongoing. So with that, I would like to close and thank my lab team and collaborators and funding sources, and be happy to answer any questions.
Tim, thank you very much. That was excellent. I'll throw the questions open to the audience. Dr. Bull.
Thanks, Jeff. Tim, great talk as always. I always learn a ton listening to you again. And, so it strikes me that all the studies that you listed show in disease states that the RVPA coupling is improved in women. Has this ever been looked at from a normal physiologic standpoint? So Mylar catheters, exercise, seeing if there's any difference in a baseline physiologic state in terms of RVPA coupling. And as you know, because you're co-mentoring with me, one of our fellows is looking at this in acute hypoxia. That is, so it's an acute change in RV function. Would that be, so does it hold up in the acute state? Does it hold up in a chronic state, or is it long-term disease state where it falls apart? So.
Yeah, thanks, Todd. That's a great question. So women, like healthy women, have higher RBEF than men. That is known, but this has only been looked at by echo or cardiac MRI. I'm not aware of any studies that looked at RVPA coupling in healthy patients and in how these patients respond to stimuli such as acute exercise or hypoxia. It's a really interesting point. I'm actually only aware of one study that looked at RVPA coupling at all. This is the one that I showed. So not aware of any data in a healthy population. It's a great point because we need to know what's normal, right? Before we know what's abnormal.
Yeah, thank you very much. That was really great. We have here on campus a pretty big trans gender program, both in children, young adults, and adults. And obviously, I'm thinking of, say, the trans female who has female levels of estrogen, but yet a Y chromosome. And do you know if there's any data on pulmonary vasculature hemodynamics or risk of PAH or anything like that in that population?
Yeah, that's a fascinating question. Actually, we've talked like a lot about that in the field, because you're right, it's a great opportunity to study these things, right? The problem is a lot of these cohorts, unfortunately, are not well phenotyped, right? It would be nice just to get an echo on all of these patients, right? But typical cohorts and registries don't really capture that, so we don't really have that data. I can tell you, I'm aware of one study that looked at female to male transgender subjects that were receiving androgens, and that was associated with decreased flow-mediated dilatation of their brachial artery. But that's as much as I know, but you're right, it's a great opportunity to study this, and since it has not been done, it would be really terrific to study this in a prospective manner.
Tim, you mentioned some of the trials that these patients could be enrolled in, and you had sort of started off by saying how we might treat these patients differently. What about treatments that are currently available today? Would you, seeing those two 42-year-old people in your office, would you treat them differently with what we have available today?
Yeah, so it's a yes and no question. I probably would be biased towards using an ERA more in the women and a PDE5 inhibitor more in the men. But PH treatment has just evolved so dramatically over the years. We now do routinely combination therapy with 2 or 3 agents. So it almost doesn't matter anymore because they kind of get anything anyway. But having said this, I'm not aware of any data that look at female to male differences in combination therapy responses, right? I think that's another interesting thing to look at, or these novel treatments like the sotatercept, right? Are there any sexual dimorphisms there? That's going to be really interesting to look at.
Yes, one other question.
Thanks, Tim. That was really fun. Well, we're working together, obviously, so maybe it's a pre-biased question, but we're really interested in differences at resting baseline between the right ventricle and the left ventricle. So you're talking about these differences, sexual dimorphism differences in response to pulmonary hypertension. Is there any evidence that the same thing is happening in left ventricular disease? And then I have a follow-up question to that.
Yeah, no, you're right, Kurt. And actually, the cardiology people, as usual, are like ahead of us. There's actually a lot of studies from the left. Sometimes. We're being recorded, right? Yeah, so actually there's a really good body of literature that females do better with various forms of left ventricular injuries, both chronic as well as acute, acute MIs, HFrEF, HFpEF. There is data that females do better there. Premenopausal females do better there. Actually, after menopause, these differences go away. But there is actually significant literature that estrogens improve healing processes or attenuate acute kind of inflammatory processes. So actually, a lot of data from the left ventricle out there.
So the follow-up question is that you know that one of the new faculty, Sue Gu, is sort of at least so far has identified that the right ventricle has a different composition in terms of the resident and potentially recruited monocytes and macrophages than the left. And the hypothesis is those could be playing a role. And you clearly pointed out all the different mechanisms that could be contributing to this right heart failure. But maybe I'm still unclear. It seems that we don't really know at the cardiomyocyte level. Is there a difference in cardiomyocyte potential for contractility between the male and the female under resting or basal conditions? And we can study that. And the reason it could be important is that the studies that we've done over the years, compatible with human clinical data, is that the heart is failing, the cardiomyocyte, even in the failing heart, seems to be dramatically protected, since when you do the lung transplant, the vast majority, probably more than 90% of people, return to, acceptable cardiac function within 5 to 7 days. So I'm just now really wondering, at the cardiomyocyte level, is there a difference between the male and female?
Yeah, that's a great question, Kurt. So actually, we're looking at this right now. We just had lab meeting about this morning. So we just started working with Casey Wolf to perform contractility studies in male and female animals with and without pH and with and without functioning ER alpha to specifically address that. It's super early. I don't really have any results to share yet. But my hypothesis is that the female cardiomyocytes will actually contract better. You're right, it's a fascinating hypothesis, and hopefully we'll learn more about that soon, but it needs to be looked at. And then also, things like fibroblasts that you're interested in, or endothelial cells, are there specific responses between the various sexes? I think it's really important to look at that.
This is great. I think it is 1 o'clock, so we'll finish up. But Tim, thank you very much. Appreciate it.
Thank you for having me. Thanks. I really enjoyed that. This is great.